Morning. Thank you all for coming. As I was looking around the room, I saw a lot of familiar faces and a lot of unfamiliar ones. So maybe to get us up and invigorated a little bit this morning, I'd like you all to stand up and introduce yourself really quickly to one person you don't know. And then we'll take seats and then get started. All right, that's great. Hopefully you made a new colleague. And we're all going to be talking more together in our small group breakout sessions right after this. Okay. So let's talk about how we can reduce emergency room visits. All right. Let me introduce myself to you all now. So my name is Sunil Kripalani. I'm a general internist at Vanderbilt. I was trained in primary care internal medicine, and then I actually didn't too much care for the notion of answering messages after clinic. And so I did a fellowship in hospital medicine and have been practicing as a general internist and hospitalist for the last 15 years. I led the hospitalist program at Vanderbilt for most of the last decade, and now one of my roles is to direct the Center for Clinical Quality and Implementation Research. And what we do is work with practices and hospitals in bringing evidence to daily care and evaluating what impact that has on the processes of care and the patient outcomes. And so working together in this Practice Transformation Network has really been a terrific opportunity to do that. This is a big collaboration, as you all know, and one of the areas that we're really trying to rally around is reducing unnecessary emergency room visits. As a practicing hospitalist, my very favorite thing is to get a page from Dr. Barrett in the emergency room saying, "Dr. Kripalani, I have a patient for you. Can you come admit them to the hospital?" Once patients get to the emergency room, some number of them are going to get admitted to the hospital. And as I've thought about this as a hospitalist, rarely are there opportunities to reduce healthcare utilization as much as when you can provide care for patients in a primary care setting for those conditions that don't ever need to get to an emergency room or a hospital. And so there's a lot of opportunity for improvement here and a lot of opportunity for cost savings, and that's what we're trying to work on together. The specific problem that we're focusing on here in looking at excess use of emergency rooms are what we call low acuity non-emergent visits. Some people call these lane visits. Now you might know these as avoidable hospitalizations or avoidable ER visits, preventable ER visits, unnecessary ER visits. These are all somewhat synonymous and are what we're trying to focus on as a Practice Transformation Network. And there are a lot of definitions for these, but one that sort of rings true is it's a non-emergency. In other words, a delay of several hours really wouldn't affect patients' outcomes all that much. Now, there are a lot of reasons for these kinds of visits to emergency rooms. The ones that are most common for low acuity visits are listed here. They include coming in for pain, having a cough, a rash, a sore throat, a urinary tract infection, or vomiting. And we actually pulled data from our own health information exchange, which is growing through VAN, and found that about 25 to 28% of visits to emergency rooms could be classified as low acuity visits, and these were the most common reasons for those visits in our own health network. Now, one thing you might think in primary care is, well, surely these visits are occurring during times of the day or night, or times of the week when the practices aren't open. And while that's true to a large extent, a lot of the visits are actually occurring during times when practices are open, when patients could be getting these visits cared for in their usual care setting, whether it's in a primary care setting, an urgent care clinic, or for some complex patients with subspecialty care needs, it could be met in a subspecialty clinic. And so if you look at this graph in the bottom right here, it shows by day of the week, these green visits are visits for low acuity conditions that are occurring at emergency departments during times of day that we would consider normal clinic operating hours. So that's another opportunity for improvement if we can redirect some of those visits to our clinic setting. So there are a lot of reasons why people go to the emergency room, and these are some of the drivers. And you may be able to think of others as well. Sometimes people are unsure of where they should be getting care. There may not be good advice or triage options available to patients. Can they call somebody and get advice about where they should go for that specific problem? Sometimes when they call, unfortunately, they get directed to the emergency room for a problem that maybe could have been cared for in another setting, in an office setting. For some patients, going to the emergency room is easy. They may think that it's always open 24/7. The signs on the freeway telling you that you only have an 8-minute wait if you go to a certain ER certainly don't help. But the reality is once you get to that emergency room, even though you might be seen within 8 minutes, there's likely going to be a significant workup, and the total amount of time spent getting care for that issue could far exceed what would have been spent in a primary care office or a subspecialty clinic with a provider who already knows that patient, already has their information. Because when patients go to the emergency room, often tests need to get ordered that may have already been done, but the information is just not available. So there's excess testing and other consequences, which we'll talk about in a moment. But along those lines also comes poor care coordination. When patients don't have good care in between visits, when they can't contact their primary care office, that may be another reason that drives them to the ER. And certainly there are a subset of patients who have substance use disorders or other mental health conditions which affect their predilection to use the ER. But I want to emphasize that's not the majority of the problem. We all also may think about so-called superutilizer patients who go to the emergency room 4 or more times a year. That's a significant group of patients, but that's also not the majority of patients who are going to emergency rooms. So for the majority of people, it's often one of these reasons. They just can't get into the office when they need to, they don't know that they could, and maybe there's nobody directing them to the right place to go. So what are some of the consequences? Well, in the one sense, there's just a lot of volume. If you look at the volume of patients coming into a large emergency room, it is hundreds of thousands of patients. Another consequence, as I started to mention, was uncoordinated care. The primary care physician or subspecialty providers may not be aware that the patient was in the clinic, in the emergency room. And so the information that was gleaned from the patient, the medications that were prescribed, don't get transmitted, and we end up with disparate information. There's a greater risk for medication errors. If patients are treated in a site when that site doesn't have a good list of their chronic medications, and patients may expect everything to be in the computer nowadays, but it's usually not, and it takes a lot of time to get accurate information on patients. There's likely going to be some unnecessary testing, either because the emergency room physician doesn't have all the information about what the patient already had done, or there's a real medical legal concern. If a patient felt a problem was urgent enough to come to the emergency room, there's a different threshold for ordering tests to rule out conditions, even though they may not be that common. ER overcrowding is another major consequence, and hospitals are actually having to expand, and emergency rooms are having to expand because of this ER overcrowding issue. And there's a lot of waste in the system too. It's estimated that going to the emergency room for a visit costs 7 times as much as having that same visit cared for in a primary care setting when we're talking about these low acuity visits. So there's a big potential to save money here. It's estimated that you could save over $4 billion a year for the healthcare system. So we're talking about some real money and real issues. So for all those reasons, reducing emergency room visits is a major priority of this health network, of our practice transformation network, of CMS, and most others who are looking at opportunities to improve care and reduce costs in our healthcare system. So one thing that we've decided to do is collaborate in developing a toolkit and being able to work with practices, whether they're primary care or subspecialty, whether they're adult or pediatric, in doing everything that we can in the outpatient setting to reduce some of these excess emergency room visits. And our focus, again, is these low acuity visits. We're not talking about reducing visits for people who are having a myocardial infarction or break their hip. Those are very legitimate ER visits. But the cough, the pain, the urinary tract infection, vomiting, these kinds of things could easily be cared for in another setting. So we formed a SWAT team. And the SWAT team includes members from Vanderbilt, outpatient care, inpatient care, emergency medicine. It includes members of the Vanderbilt Health Affiliate Network, includes members of the Safety Net Consortium, people from the Baptist Health System, and we're all working together to develop a toolkit which we can spread across the practices, and our coaches will be able to work with the practices in helping the office settings implement some strategies to improve on whatever they're doing right now to further reduce some of these excess visits. And what I'd like to do in the remaining of my time is introduce you to the toolkit. It's broken into 5 sections. I just want to share with you the structure and examples of some of the things that are in it. And then we'll actually ask for your feedback afterwards. So the toolkit's broken into 5 sections. One is about improving access, another is about triage. Then there's patient education, how to collaborate with local institutions, and some tips for doing post-emergency room follow-up to learn about why patients went there and provide some education. Okay, so in the first section, which is about improving access, these are some of the topics covered. One is how to survey patients about their ease of clinic access. Another relates to time slot utilization. A big part of improving access to care is making sure that in the clinic template, appropriate steps are taken so that patients can get urgent care needs met in the clinic setting. Is the appointment length aligned with the need? So is the right amount of time being offered for new patient visits, follow-up visits for simple patients, follow-up visits for complex patients, post-hospital visits, et cetera? What are some of the protocols to work through urgent care issues when they do get called into the office? And how can we ensure availability of same-day and next-day appointments? So for each of these 5 areas in the toolkit, there are specific examples and tips which we've gleaned from other national initiatives and from the medical literature, because there are a lot of strategies that have been proven effective in reducing emergency room visits. So just for example, in the toolkit is a survey which you could modify for use in your practice, but this is a starting point. And the idea here is that patients in the clinic could be surveyed so that they tell us how easy it is for them to get their needs met in the clinic. This could relate to how easy is it for them to schedule an appointment in a timely manner. When they have an urgent medical issue, are they offered a same-day appointment or a next-day appointment? Do they know how to get in touch with somebody during business hours or after traditional business hours? Now, it's not necessary to survey all the patients in a practice about these things, but some sample of patients, maybe 50 patients or so, who are asked to complete this survey really could provide useful information about the opportunities for improvement. And so we wanted to provide a starting point for practices who'd like to do that as part of their efforts to reduce emergency room visits. So when you get information like this, or however you get it, maybe you talk to your staff and brainstorm about opportunities. Maybe you have conversations with patients about their access. These are some of the things to consider for your practice as you think about your opportunities for improvement. Are your patients satisfied with their current ease of access to the practice? Is there a need to offer evening hours? If yes, is there a way to test that in a small way to determine how valuable it is? You're recognizing that's a big commitment. Is there a way you can test that in a limited way to see if it's actually being utilized by patients? What about weekend hours? And similarly, is there a way to test that? And are your patients aware of how to contact their provider after hours? And what improvements can you make? So these kinds of questions and having meetings within your practice with all the staff, including the front desk, the nurses, the healthcare professionals. Everybody can get together and share ideas about opportunities for improvement. So the next part of the toolkit relates to triage. When people call in for any kind of issue to the practice, what is that process? If a patient would like to be seen that day, is there a structured approach to determine if that appointment is given? Are there nursing triage protocols that empower nurses to, based on the patient's complaints, go through a structured protocol which has been vetted by the prescribers in the practice about what can be offered to that patient? What about the after-hours messaging? When's the last time you listened to the message that your patients get after hours? Does that need to be updated? How is it steering people? And I'm going to show you an example of that in a moment. Another important point of triage is, has your practice considered an after-hours call service or a nurse advice line? Or if you already have one, is it meeting all the goals that you would want it to meet? What's its messaging like? And is there a physician or nurse on call for urgent needs? So there's a lot of things to consider, again, when it comes to triage. And whatever your source of information is for this dialogue within your practice, these are some of the things that you all can talk about and think about. What is the current protocol when people call in for urgent care needs? Who determines if that patient's given an appointment? Is the patient instructed by a receptionist or a nurse? Is there an escalation process to speak with a nurse or a doctor? Are there clear guidelines for when to tell a patient to go to the ER? Now, this is a really key one. And we may find that there's variability among staff even within a practice in terms of what advice patients are given. And are there telephone triage protocols appropriate for your practice? In the toolkit, there are actually examples of some protocols that exist, for example, when patients call in with fever for their child. And there's structured protocols that have specific trigger questions which have been vetted by a number of sources and are available to provide guidance for practices who may find that useful. I mentioned after-hour messaging. I know a lot of times when I call any medical provider and get a message, the very first thing is, if this is a medical emergency, hang up and dial 911. Is that really appropriate? Should the messaging instead say, thank you, we're currently closed. There's somebody available to help you. If your problem's not really urgent, you can leave us a message and we're going to call you back first thing in the morning. And then maybe the last thing is, if you really have a medical emergency, go to the emergency room. And simply looking at the messaging and the order in which things are communicated and making sure that's paired with the services that your practice offers could be a simple way to align patients' behaviors and steering them in a way which you actually would prefer. So the toolkit has examples of this. Recognizing that practices have different access to resources. Some may have an after-hours call service. Some may have a system in place where they page a healthcare provider from the practice. Others may have a recorded voice message only. Some may have nothing. So we're trying to provide examples of what practices with each of those levels of resources could do. So the third part of the toolkit has to do with patient education. How can we provide information to patients about the office hours, the services that are available, what to do after hours? Is there a website that they can refer to for information? What are the opportunities to educate patients about seeking care? And educating them about when it's appropriate to go to the emergency room. What are our opportunities to educate patients about alternatives to the emergency room? People may just not be familiar with those. So there are really a lot of opportunities here, and your practices may be using some of them, but maybe you'll find some other ideas to add to whatever you're doing. You may have a practice website where you can put information, but people need to be directed to that website. So are you providing the website's address in the documents that patients get? When they get an appointment reminder, for example, does it have the website on there just for their reference? Do you give a new patient packet to people who are new to the practice? That's a great place to put information about business hours, after-hours services, and provide some guidance about how people can best access the resources that are available to them. Maybe when patients check in at the front desk, they can be given a postcard by the receptionist that they could tack up on their refrigerator. They could be given a flyer or a refrigerator magnet with practice information. Again, something that is front of mind rather than just the number 911, which everybody knows, so that people have a place they can go quickly when they really feel like they have an urgent medical need. You may want to put a footer on all your patient documents, whether it's the practice letterhead or bills or anything, which regularly communicates and reinforces this information, so that, again, that people have it on hand. Messaging through many different channels is going to be important for people who are getting information from different ways. I don't know if your practice has a Twitter account. Think about all these things as a way of reaching your patients. One thing that we developed for the toolkit, which was based on models that we found from other medical centers, was some posters or flyers, which are freely available for you to use. Feel free to modify them. We're going to distribute all this to you soon in an electronic fashion. And what we tried to do here is structure some guidance that you could post up. You could print as posters in your office and put them up. You could send them out as flyers. You could hand them out to patients when they check in, whatever you'd like to do. You can brand it for your practice. That's fine. Showing people the kinds of things that they should go to their primary care office for, the kinds of things that they should go to an urgent care center for, and the kinds of things they really should go to an emergency room for. And this general information can be really helpful for people who have difficulty really sorting out what level of care can be provided in these different settings. And the cost varies a lot, and it's important for people to know that, especially as more and more individuals have high deductible healthcare plans and different copays depending on their settings. So we developed one of these guides for adults, which is shown here, and then for pediatric care. So the next part of the toolkit has to do with local collaboration. So we can accomplish a lot just within our own practices by talking to our patients, looking at our access, triage protocols, by doing patient education. But if you really want to kick it up a notch, collaborating with other clinics and hospitals nearby is the next step. And so in the toolkit, we provide some guidance about reaching out to emergency rooms that may be most often used by your patients, building relationships with those physicians and administrators, and even partnering with urgent care clinics, which might be part of your health system or they might be retail clinics. But the idea here is to develop a relationship so that you have a trusted provider that you can direct your patients to during times when you're not going to be able to provide that service yourself in the office setting. So what does this look like? The basis for collaborating with emergency rooms or urgent care clinics is shown here. We can build relationships with the clinicians and administrators to try to get a two-way referral relationship. Ideally, when a patient presents to an urgent care clinic and they need information about the patient's usual medication list, they already have a relationship with that patient's practice if it's nearby, and can contact that practice. And that practice knows to elevate that for immediate response to the urgent care center and not wait 2 hours, because then the information's not going to be useful anymore. And the same would go for an emergency room. Similarly, when the patient's visit is completed, the emergency room or urgent care center in this two-way referral relationship would know, we need to send information back to that practice today, not wait 3 days or a week, because the patient may have a follow-up in that practice 2 days later. The timeliness of sharing that information is really probably the most important part of these two-way referral relationships. And collaborating to develop procedures around the timeliness of that would be part of developing this bond. So as a practice, you may identify that there's an emergency room and 2 urgent care centers that are nearby to where your patients live, to which you would like to direct your patients when the needs arise. Wouldn't it be great if every month then you could get a list of patients who actually went to those facilities? Or do you want to try to get that every week? Now, it would be great to get that in real time, but we may not have the information exchange set up for that purpose just yet, especially if it's outside of network. But building this relationship and both parties coming to the table and saying, you know, I can't do this every week, but yeah, we could do that every month. Might be a really useful way for you to keep track of utilization of patients that are followed in your practice. And the goal here shouldn't be to try to get information on every emergency room visit. If you find a couple of emergency rooms where at least half of your patient visits are going, that's a great place to start. We're not trying to prevent all emergency room visits. We're trying to just chip away. If we can reduce excess emergency room visits by 5%, that would meet our goal. And there's a lot of opportunity here when we think about 25% of visits potentially being unnecessary. Are there certain priority populations or patient groups that you want to focus on? Does your practice care for a small group of people with really complex needs that just need to be seen more often? Do they have significant pain issues for which they're seeking care in acute care settings on a regular basis? Is there a group of patients with a substance use disorder or another mental health disorder that you might consider a super utilizer, where you want to develop a protocol for their care for those times they do present to the emergency room? We've started to experiment a little bit with that at Vanderbilt, and we're still learning how to best do that. But there's ways of getting started with a small group of patients who you think are just different and have specialized healthcare needs, and having a partner in the emergency room or in an urgent care setting who can see those patients after clinic hours or on the weekend could really be helpful. You might want to develop shared educational materials. Maybe you partner with the urgent care setting in handing out the very flyers that I showed previously, so that they can also be part of the patient education for when patients should go where. And there may be more robust opportunities to collaborate on quality of care, as increasingly we're held responsible for all the decisions that everybody in our healthcare network makes, or everybody that we're collaborating with makes, because those affect the medications patients are on, the services they're getting, et cetera. The fifth part of the toolkit and the last part has to do with following up with patients who have gone to the emergency room. Do you have a practice in place to call patients who've been to the emergency room sometime in the last 3 days or in the last week? Find out why they went there. Answer any questions they might have about their medical condition, the medications they might have been prescribed, additional testing that needs to be scheduled. What a great opportunity to educate people on alternatives when appropriate if they went to the emergency room, for example, because they were having pain in their shoulder, or they needed stitches taken out, or they had a cough, or a urinary tract infection. Were there any barriers that they experienced that prompted their visit to the emergency room? What a great opportunity to get feedback about those barriers very close to when they happened, so that you could add that as a consideration for how you might open up access or address that barrier in some way in the outpatient setting to prevent that next emergency room visit. So in the toolkit, we have examples of a phone call script, for example. This shows some of the topics that it goes through. We've been doing these post-ER phone calls within the Vanderbilt health system for a while now. And in those phone calls, we ask about the reason why the patient went to the emergency room, what kinds of instructions were they given at discharge, and what questions do they have about it. Ask them about medications that were changed, what follow-up appointments are necessary or tests need to be done. Then we start asking about, did you try to call a practice or your regular care provider before you decided to go to the emergency room? Maybe you did that and somebody actually told you to go to the emergency room. Tell me about that. How did that all work? And as we have nurses making these phone calls, and hearing about the situation provides input which we can feed back into our healthcare system about opportunities for improvement. And then there's a patient education component to the phone calls. Again, if a visit appeared inappropriate, to provide non-judgmental education about situations where an ER really should be used and other places where people can get care for less acute issues. So let me just summarize with this slide. Some of these strategies are easier than others. And so here I've got many of the strategies laid out in terms of degree of difficulty. If your practice is just getting started in trying to learn more about your patient's ER usage and reduce it, look to the left column here. A great place to start would just be giving a survey out on a clipboard to 50 patients who come in the door of the practice. Learn about the challenges they're having accessing, learn about how familiar they are with other sources of care. Talk about that information as a practice, and think about one thing you might be able to do as a result of that information. Use educational materials, whether it's a flyer or maybe while patients' vital signs are getting checked. They can be asked how familiar they are with urgent care centers in the area for needs that come up. Do they know who to call when they have a problem after hours? And then providing some very short, brief educational messages could be useful. Look at the after-hours messaging and the services that are provided. Train staff to provide the kind of triage and referral that the practice decides it wants to provide. And making sure that patients have their phone number to reach some provider of care after hours when they have urgent care needs. These are all pretty easy. What's a little bit harder is looking at the appointment templates and thinking about how to incorporate same-day and next-day visits. And this is not terribly difficult, but if your practice feels like it already has a jam-packed schedule with follow-up visits, the first time you start offering same-day visits, there can be a lot of anxiety about keeping a template slot open or 5 or 10 template slots open. But once you decide that that's something you want to do, there's some strategies for how to best do that. And Dr. Powell's actually going to talk about that later today. What about the after-hours services? Does your practice use a call service? Do you want to evaluate how they're doing? Or do you want to newly engage a call service? And what about calling patients after their ER visits? So these are things that might take a little bit more time, and that's why they're in the intermediate column. And then advanced, but not necessarily difficult, are looking at expanding office hours, partnering with local clinics, or collaborating with local ERs. These are going to take a more concerted effort. They're going to take more time. They're going to take a different level of engagement than your practice may already have, especially as it gets to the local collaborations. But if you're already doing a lot of the simple things, then you can really build on that with some of the more advanced strategies. So in your folder, you have the toolkit. This is version 1.0. What we'd like to do is get feedback from you all, not right now, but take it home, read it over. We'll reach out to you and ask for feedback you have. Did everything make sense? Are there areas that you think are just ridiculous that should be cut from the toolkit? Are there things that you would like added? Do you have any examples of successful practices that you want to share, maybe with others? So we've got some phone call scripts, for example. Do you have a message you're really proud of? Do you have a flyer or a postcard that you really like, that you put some energy into, and you want to let other practices use it? Give us your feedback so that we can do version 1.1 of the toolkit, and then we're going to spread that across the health network, our practice transformation network, that is. And we'd like to actually do that within the next 2 to 3 weeks. Then the coaches are going to be using these toolkits to work with the practices in developing tailored strategies appropriate for each practice and each group of patients they care for, so that we can all start working together in this area. Again, our goal is to reduce excess emergency room visits by 5%. And I'm pretty sure we can get there just by implementing some basic strategies that have been proven effective in other efforts. So I'm going to check in with Heather and see if we have time for a couple questions or how you want to do things next.
Anyone who has questions.
Yeah. So again, thanks so much for being here. If you have a couple of questions you want to ask, feel free to come to the mic, or Heather can come to you. And then after this, we're going to move into some small group discussion about how might you build some of these collaborations. Yeah, there's a question in the back.
Thank you very much. This is an amazing presentation and an amazing amount of work that's gone into this toolkit. So thank you for that. First of all, I'm Beverly Puckett. I'm one of the PHAs with VAN. I work with the pediatrics groups. away from this separately, one of the questions that I'm frequently asked by practices, and this is kind of an aside, is on the flip side of this, what are ERs doing to discourage patients from coming in? Of course, peds is a little bit different. Peds is special, because we have the TennCare patients that are going in for free care. So, but for the adults also, what are ERs doing to encourage patients to go back to their PCPs?
That's a terrific question. I'm actually going to ask Dr. Barrett to weigh in on this as well. One of the challenges for emergency departments, as we know, is once a patient comes there, there's a legal responsibility to provide care for that patient. One of the strategies I've seen used most is developing different levels of care within an emergency room or emergency department. By the way, we intentionally called it an emergency room here because that's what patients call it. But in healthcare, as we think about emergency departments, there often is a low acuity area or an urgent care area, a more typical ER bed, and then like a trauma bay or a more acute care area. And having the ability to triage patients to different areas, although they're in the emergency room and get care in the emergency room, it allows provision of a lower intensity, reduces the cost of the visit perhaps, and the segmentation in the emergency room is part of addressing that need. But I'd love to hear Dr. Barrett's comments about things that he's seen emergency departments do. So he's medical director of our emergency department. If you could take a mic and weigh in, that'd be great.
So, good morning. To answer your question outright, really we don't discourage anyone from coming because of federal law that anyone who steps foot pretty much on our property, we have to perform a medical screening exam or we are at risk for EMTALA violation. That being said, there are educational opportunities, and I'll give you one example. With the expanding opiate problem in Middle Tennessee, there's been a misunderstanding that many hospitals admit patients for opiate detox. And so we'll have a large percentage of people come to Vanderbilt seeking opiate detox, which unless you're pregnant is not something that you'll get admitted for. And so we came up with a pathway and a very detailed discharge instruction packet, which we'll go through with people who present for that complaint, explaining to them this isn't something that people get admitted for, talk to them about resources that are available, but also kind of encouraging them, you know, for any sort of future visits for an isolated opiate withdrawal issue to seek treatment in some of the behavioral health clinics or the outpatient kind of detox as opposed to come into the emergency department. But in general, as far as telling somebody don't come to the emergency department the next time, we actually really take the opposite approach for many patients, especially we're in a unique environment here where we take care of a very sick population, that we encourage people, if somebody comes in with chest pain, it's found out not to be due to their heart, we say, you did the right thing. Because we'd much rather have somebody come and be able to send them home than have somebody stay at home and have a massive heart attack or a stroke. So.
Heather, I want to turn it back over to you. Thank you all so much for joining us today, and we look forward to working with you all in the future.